Hi, my name is Taylor Gish, and I'm a PGY1 pharmacy resident at St. Thomas West Hospital. The title of my project is Nafcillin versus Cefazolin for the treatment of methicillin-susceptible Staphylococcus aureus bacteremia. My advisors are Doctors Jarrett Warden and Chris Larkin, and we have nothing to disclose. This study took place at St. Thomas West, a 541-bed tertiary care facility and a member of Ascension Health, which is the nation's largest not-for-profit health system. For this presentation, it is important to note that infectious diseases is consulted for all patients with Staph aureus bloodstream infections. A little bit of background on the topic at hand. Mortality rates can reach 30% for those infected with methicillin-susceptible Staphylococcus aureus bacteremia, which I'll now refer to as MSSA. Anti-staphylococcal beta-lactam antibiotics are the preferred treatment options. At St. Thomas West, the recommended first-line agent is Nafcillin. However, Nafcillin has a very frequent dosing schedule, high cost, and carries with it numerous side effects, especially compared to the antibiotic Cefazolin, which is also used for MSSA bacteremia. So Cefazolin may be an alternative treatment option. However, there is concern over the use of Cefazolin because of possible treatment failure due to the inoculum effect, which could possibly be present in 1/5 of clinical MSSA strains. After doing a review of the current literature, I found one retrospective cohort and 2 meta-analyses that all concluded that Cefazolin was at least as effective as Nafcillin for the treatment of MSSA bacteremia and may be associated with less side effects. So the purpose of the study is to compare patient outcomes between patients receiving Nafcillin or Cefazolin for the treatment of MSSA bacteremia. The primary endpoint is to determine if any difference in treatment failure exists for patients receiving Nafcillin or Cefazolin for the treatment of MSSA bacteremia, and treatment failure is a composite endpoint of switching antibiotics due to lack of clinical improvement or adverse reaction, recurrent MSSA infection, persistent bacteremia, or MSSA bacteremia associated in-hospital mortality. Secondary outcomes include length of stay, time to clearance of cultures, and adverse drug reactions, including nephrotoxicity, neutropenia, thrombocytopenia, and hypokalemia. This was a single-center retrospective chart review of patients admitted to St. Thomas West Hospital being treated with either of the 2 drugs for MSSA bacteremia between January 1st, 2017 and December 31st, 2018. Patients were included if they were 18 years old or older and had MSSA bacteremia treated with Nafcillin or Cefazolin. They were excluded if they were hemodialysis or peritoneal dialysis patients or did not have follow-up cultures. From baseline data collection, we collected demographics, admission status, laboratory data, antibiotic information, and other pertinent objective data. Categorical data was analyzed using the Fisher's exact test and reported as ends with percentages. Since data was non-parametric, meaning not normally distributed, the Mann-Whitney U-test was used to compare continuous data, and it was reported as medians with interquartile ranges 25 to 75%. A p-value of 0.05 was used to determine statistical significance for both sets of data. So we had 50 patients in the Nafcillin group and 15 patients in the Cefazolin group, and both groups were similar at baseline, including rates of concurrent infection, source control, and infection type, which is very important when concerning a bacteremia. As for our primary outcome, 46% of patients in the Nafcillin group experienced treatment failure, whereas 20% of patients in the Cefazolin group experienced treatment failure. This is a big difference between the 2 groups, but it failed to show statistical difference. However, there seems to be a trend towards statistically significant difference, so it makes you wonder if there was a larger patient population, would this treatment failure be statistically significant? When breaking down the composite endpoint treatment failure, patients in the Nafcillin group experienced treatment failure due to switching antibiotics due to lack of clinical improvement or severe adverse reaction, persistent bacteremia, and MSSA bacteremia associated in-hospital mortality. Patients in the Cefazolin group experienced the treatment failure only due to switching of antibiotics. When looking at the percentages of the group, though, 20% of the Cefazolin group experienced this outcome, whereas 12% of the Nafcillin group experienced the same outcome. It is important to note, however, especially when looking at the secondary outcomes that we'll go to on the next slide, that the Cefazolin group had the antibiotic switch mostly due to lack of clinical improvement per the ID physician documentation, not adverse reaction. As far as secondary outcomes go, there was a statistically significant difference between the two groups in time to clearance of cultures, with Cefazolin resulting in a median of 3 days and Nafcillin 4 days, leading to a p-value of 0.025. However, a difference of a day may not be clinically significant. When looking at the adverse reactions, a significantly higher number of patients experienced hypokalemia in the Nafcillin group, 18 patients or 36% of the group, compared to Cefazolin, where 0 patients experienced hypokalemia, leading to a p-value of 0.007. This is thought to possibly be due to potassium wasting from antibiotic cellular redistribution of potassium in the body, so not necessarily a loss. This is why we've seen that repleting potassium commonly does not fix this problem. So from this research, we can conclude that there was no statistically significant difference in overall treatment failure between the two groups. Hypokalemia was experienced significantly more with Nafcillin, and there was shorter time to clearance of cultures with Cefazolin. So these results support a reevaluation of Cefazolin's role in the treatment of MSSA bacteremia. Some limitations of the study include that it was a single-center retrospective cohort, so there may be some inherent bias, and there were confounding variables that could have affected survival, and there was a small patient population. In the future, I would like to evaluate comorbid conditions such as cancer or HIV and expand the study to include other hospitals and therefore increase patient population and make these results more generalizable. Since it seems like the primary endpoint was approaching statistical significance, it makes me wonder if I had a larger patient population, would the results be statistically significant? So based on this study, Cefazolin could be a first-line agent for MSSA bacteremia, but additional larger studies need to be done. So my research objective is to determine if any difference in treatment failure exists for patients receiving Nafcillin or Cefazolin for the treatment of MSSA bacteremia. My self-assessment question is, how do patient outcomes compare when using Nafcillin or Cefazolin to treat MSSA bacteremia? And to answer that, there is no difference in treatment failure rates, but there is a difference in rates of hypokalemia and time to clearance of cultures based on this study. And my contact information is at the bottom of the screen. Thank you.